Welcome to PB&J number 78. Today, we are covering hemoglobinopathies in pregnancy. By the end of this video, you should be able to answer who needs screening, what test comes next, and what changes when the patient is pregnant. Don't forget to subscribe and check the description for more resources. Here are the PB78 summary of recommendations. Individuals of African, Southeast Asian, and Mediterranean descent are at increased risk and should be offered carrier screening and genetic counseling if both parents are carriers. Solubility tests alone are inadequate. Prenatal diagnosis is best done by DNA analysis of cultured amniocytes or chorionic villi. Let's make the vocabulary less annoying. A hemoglobinopathy is the umbrella term. Under that umbrella, you have two big buckets. First, structural problems, where the hemoglobin is built incorrectly, like hemoglobin S. Second, production problems, where the body does not make enough of a globin chain. That's thalassemia. Sickle cell trait means carrier. Sickle cell disease means clinically significant disease. You should memorize this hemoglobin structure. Adult hemoglobin A is 2 alpha plus 2 beta. Beta chain production grows in the third trimester. Fetal hemoglobin is 2 alpha plus 2 gamma. Production dominates in the 12 to 24th weeks. The alpha globin genes live on chromosome 16. Beta globin lives on chromosome 11. I remember this by thinking the alpha letter looks like the number 6 sideways. When you think of sickle cell disease, just think of hemolysis plus vaso-occlusion. It is an autosomal recessive disorder caused by an abnormal beta globin chain. The key idea is when oxygen is low, hemoglobin S changes shape and the red blood cell sickles. Once cells sickle, they do two bad things. They break apart, causing hemolysis, and they clog small blood vessels, causing vaso-occlusion. That's the whole disease in one sentence: hemolysis plus vaso-occlusion. There are two main genotypes of sickle cell disease. Hemoglobin AS is sickle cell trait, which is usually asymptomatic with more HbA than HbS. Sickle cell disease is hemoglobin SS. We won't go into details, but HbSC and HbS beta-thalassemia can also cause clinically significant disease. Pregnancy is basically a stress test for sickle cell disease. You already have chronic anemia, vaso-occlusion, and organ vulnerability. Then, pregnancy adds increased oxygen demand and major hemodynamic changes. So these patients are at higher risk for pain crises, infection, specifically encapsulated bacteria due to autosplenectomy from sickling, preterm birth, fetal growth restriction, and stillbirth. For the fetus, the main concern is placental and growth-related risk: fetal growth restriction, preterm birth, stillbirth, and pregnancy loss. So there would be extra fetal surveillance with serial growth ultrasounds and antenatal testing. A pearl to note is that if the patient is experiencing an acute pain crisis or receiving narcotics, their NST can look temporarily abnormal, so be sure to interpret it with context. For triage, be aware of the sickle cell emergency, which is acute chest syndrome. It's, quotes, to happen in 6.5% of patients with sickle cell disease. The STEM usually present with diagnosis of sickle cell disease, chest pain, fever, hypoxia, and a new infiltrate on CXR. Do not brush this off as pneumonia or normal dyspnea in pregnancy. Acute chest syndrome can deteriorate quickly, and the main idea is O2 supplementation, antibiotics, pain management, IV fluids, blood transfusions. Now switching gears from sickling to thalassemia. Thalassemia is not a structural hemoglobin problem. It's a chain production problem. The lab clue is microcytosis, which is MCV less than 80. So if the MCV is low, but ferritin is normal, don't keep ordering iron. Think thalassemia. Alpha thalassemia is a numbers game. There are 4 alpha globin genes, and severity depends on how many are missing. Lose 1, it's silent. Lose 2, trait. Lose 3, HbH disease. Lose all 4, HB Bart's, which is the catastrophic one, and includes hydrops fetalis, fetal demise, and increased maternal risk, including preeclampsia. This slide is very board relevant. There are two configurations when talking about at least two deletions in alpha thalassemia, which is also an autosomal recessive disease. In cis configuration, both deletions are on the same chromosome. In trans, one deletion is on each chromosome. Cis is more common in Southeast Asian ancestry and creates the risk that both parents pass on a chromosome with no alpha genes, leading to HB-Barts. If you look at the chromosome with both genes missing, plug that into the Punnett square, and there would be a 25% chance of having HB-Barts, which is deletion of all four. Moving on to beta-thalassemia. Beta-thalassemia trait gives you low MCV and elevated HbA2, specifically one that is greater than 3.5%. Beta-thalassemia major is the severe form, profound anemia, transfusion-dependent, iron overload issues. Traditionally, screening is targeted to higher-risk ancestry groups, including African, Southeast Asian, Mediterranean, and others. But people may not know their ancestry, and populations are mixed. So if you see unexplained microcytosis, screen for it. For screening, start with a CBC and RBC indices and use hemoglobin electrophoresis to identify variants. Note that for alpha thalassemia, you need to order DNA-based testing, like a Southern blot or PCR, as an electrophoresis cannot identify it. If the MCV is low, check ferritin first, because iron deficiency is common. There is a screening test called SickleDex, and it tells you if sickling is present, but it does not tell you whether the patient has trait or disease, and it misses other important hemoglobin variants. Low MCV plus high HbA2 equals beta-thalassemia trait. Low MCV plus normal ferritin plus normal electrophoresis means think alpha thalassemia and order DNA testing. HbAs has more A than S. HbSS is mostly S and essentially no normal adult hemoglobin A. For screening, it helps to stratify fetal risk. If both parents are carriers, the next step is genetic counseling, which should cover inheritance, disease severity, prenatal diagnosis, and reproductive options. Your two diagnostic testing are CVS at 10 to 12 weeks, amniocentesis after 15 weeks. Okay, so basics on management of sickle cell disease in pregnancy. First, these patients need to be with MFM and consider consulting hematology and anesthesia. Second, their prenatal vitamin should include folic acid to 4 milligrams instead of the 0.4 milligram standard because red blood cell turnover is high. Third, avoid crisis triggers, dehydration, cold exposure, and stress. Lastly, sickle cell disease itself is not an indication for cesarean delivery. When a pregnant patient with sickle cell disease presents in pain, you should highly consider that this is a sickle pain crisis. You should have high alert for acute chest syndrome, infection, dehydration, severe anemia, and cholecystitis. Overall management is prompt analgesia, O2 goals of greater than 95%, and involve the consults like hematology and anesthesia early. Not every pregnant patient with sickle cell disease needs routine prophylactic transfusion. There's no clear pregnancy outcome benefit for everyone. Instead, transfuse is indicated with worsening anemia, acute chest syndrome, severe crisis, hemorrhage, or sepsis. The goals to remember are HbS to about 40% and bringing the hemoglobin to around 10. For thalassemia, management depends on severity. Trait is usually mild. Avoiding giving repeated iron for beta-thalassemia minor when iron deficiency has not been documented. Beta-thalassemia major is a different situation entirely. Pregnancy should only be considered with normal cardiac function and specialized care, with transfusion support to keep hemoglobin near 10. Here are the high-yield pearls from PB78. Sickle-Dex alone is not adequate screening, unable to differentiate HbAs versus HbSS. Screen with CBC, RBC indices, and hemoglobin electrophoresis. Low MCV plus normal ferritin plus normal electrophoresis equals consider alpha-thalassemia DNA testing. Beta-thalassemia trait, low MCV plus elevated HbA2, greater than 3.5%. HB-Barts, all 4 deletions, causes hydrops fetalis. If both parents are carriers, refer for genetic counseling. Diagnostic testing, CVS at 10 to 12 weeks or amniocentesis after 15 weeks. Sickle cell disease in pregnancy increases maternal and fetal risk. Give folic acid 4 milligrams daily in sickle cell disease. Hydroxyurea is not recommended in pregnancy, teratogenic. Acute chest syndrome equals pulmonary infiltrate plus fever plus hypoxemia. Routine cesarean delivery is not indicated for sickle cell disease. Prophylactic transfusion is controversial. Transfuse for clinical indications. When transfusing, target HbS around 40% and total Hb around 10 grams per deciliter.
Okay, let's review with some questions. Question 1. A pregnant patient of Southeast Asian ancestry has microcytic anemia with normal ferritin and normal hemoglobin electrophoresis. What is the next best test? The correct answer is C. Southeast Asian ancestry, low MCV, normal ferritin, and normal electrophoresis is the combination for alpha-thalassemia. Since electrophoresis can be normal in alpha-thalassemia trait, the next test is DNA-based testing for alpha-globin gene deletions. Next question. A patient with HbSS disease presents at 30 weeks with chest pain, fever, tachypnea, hypoxemia, and a new pulmonary infiltrate. What is the most concerning diagnosis?
The correct answer is B. In a pregnant patient with HbSS, chest pain plus fever plus hypoxium plus a new infiltrate is acute chest syndrome.
Okay, last question. A pregnant patient with sickle cell disease asks whether she needs a scheduled cesarean delivery because of her diagnosis. What is the best response? The correct answer is D. Sickle cell disease alone is not an indication for cesarean delivery. This procedure should be reserved for standard obstetric indications. Thanks for watching PB&J. If this made hemoglobinopathies feel more manageable, please hit the subscribe button for more high-yield reviews. Until next time.